Okay, so it's going to YouTube, and whenever you're ready, here in about 10 seconds, go ahead and go for it.
Well, good afternoon, everyone, and I want to thank you for joining us today. My name is George Monks. I'm president of the Oklahoma State Medical Association, and it's my great pleasure to welcome you all today for today's discussion on a very important and timely topic, racial health disparities in Oklahoma and America. Just a couple of housekeeping notes before we get started. First and foremost, we'd like to say thank you to our other presenting sponsor who's made today's CME possible. Thank you, Plico. Really appreciate you. Also like to thank OSMA CME manager Sandy Deba, Sharon Westmoreland, Jennifer Dennis Smith for pulling this all together. Appreciate you guys. Information on how to receive your CME credit today can be found on our website, and that is okmed.org, okmed.org. You can also find copies of today's presentation and more information about our speakers there. So it is with that, and it's my honor to introduce our two presenters today, Dr. Patrice Harris, who is the immediate past president of the American Medical Association. She's a psychiatrist from Atlanta. She was the 174th president of the American Medical Association, and she is the organization's first African-American woman to hold this position. Dr. Harris has a very diverse experience as a private practicing physician, as a public health administrator, a patient advocate, medical society lobbyist. She's a fellow of the American Psychiatric Association. Dr. Harris continues in private practice and currently consults with both public and private organizations on health service delivery and emerging trends in practice and health policy. She is the adjunct assistant professor in the Emory Department of Psychiatry and Behavioral Sciences and an adjunct clinical assistant professor in psychiatry and behavioral sciences at Morehouse School of Medicine. Our second presenter today is Dr. Jabraan Pasha. He is a native of Tulsa, Oklahoma. He received his medical degree from the University of Kansas School of Medicine and completed his internal medicine residency training at the Mayo Clinic, Arizona. Currently, he is an assistant professor of medicine and assistant dean of student affairs for the OU School of Community Medicine. He's also the president of the Tulsa chapter of the American Heart Association. One of his major academic interests is the impact of implicit bias on patient care and society. He has presented his workshop, Unlocking Implicit Bias, over 50 times, including sessions for the American Association of Medical Colleges, Mayo Clinic, and internationally in Paris, France, and Portugal. With that, we will begin today's formal presentation. What we plan to do is have Dr. Harris and Dr. Pasha each make their presentation, and then hopefully at the end of this, we'll have time for questions, which can be posted via live chat during the live broadcast for today only on July 17th. Please note that the chat function is just for this live event. If you have any questions, please type them in the live chat section of the YouTube page. Time permitting, we'll try to get to as many of those questions as possible at the end of the presentations. I just have to say this, the faculty, OSMA, CME Planning Committee, reviewer, and moderator have no relevant financial relationships to disclose. The OSMA CME manager has reviewed all information and has resolved all conflicts of interest if applicable. Dr. Harris, the floor is yours.
Well, thank you, Dr. Monks, and it is an honor to be on this panel today with Dr. Pasha. I have to say that it is critical that we have conversations about health inequities. Now, this current pandemic, I think, has brought into stark relief so many things about our current health and healthcare delivery system. And so I want to thank OSMA for the opportunity to discuss these issues and really try to think about solutions and a path forward. Last November, the last time the AMA House of Delegates was able to meet in person, I talked about physicians matching the moment. And clearly, without question, physicians have matched the moment on COVID-19. And so before I begin to delve into my talk around inequities and some of the work that the AMA is doing, I want to just thank all of the physicians, of course, my physician colleagues, but also the nurses, also those who come to work every day and clean our facilities, right? Those who cook the food for the doctors and the nurses that are working on the front lines. I just want to say thanks. Now, I will say thanks is not enough, and we have to make sure that our physician colleagues, other health professionals are supported and supported appropriately so that we can do our work in the safest manner possible. But I just wanted to thank you personally and also on behalf of the American Medical Association. But again, this COVID pandemic has brought into stark relief so many issues. Health inequities we'll be talking about. But where we need to go, what is the path forward for health care delivery as we have seen the need for telehealth? Certainly not a panacea. As we all know, in healthcare, there is no one-size-fits approach that's going to solve all problems, and there's no one thing that's going to solve all of our problems. But healthcare, what about public health preparedness, or I have to say, the lack thereof? I was public health director for many years, and we certainly need to add that to our to-do list. Mental health, I am a psychiatrist, but I think, again, COVID has brought into stark relief issues around mental health. But today, let's focus a little bit on equity and then some of the work that the AMA is doing around COVID. And so I do have some slides today. And again, my hope is that we, and actually I know that we will, continue again to meet the moment we have thus far and continue to demonstrate physician leadership in advancing health equity, because that is so important as we begin these conversations. And again, these are not quick and easy solutions, and they will require not just talk, but action after we get through COVID-19. Now, you've heard a little bit about me and read my bio, I'm sure, but a point I want to make is my inspiration for becoming a physician was actually a TV doctor. And the younger folks in the audience will have to Google Marcus Welby. But what I liked about Marcus Welby, TV doctor, family medicine, he not only cared about his patients inside the exam room, but I saw that as a physician, he had a platform to make change. Never did I dream that I would have the platform, of course, of the American Medical Association. But again, the AMA, OSMA, even being a physician leader day to day in our communities, because leaders and leadership is not about the title or the parking space or the corner office. It is about the work. And so back to the title today, it is important that physicians lead, again, on all of the things that I mentioned that are on our to-do list, but certainly regarding equity. We have to look inwardly, as we are doing at the AMA, and I'll speak a little bit more about that later. But we have to, again, advance, make sure we are demonstrating leadership as we advance concepts around equity. Of course, I just want to do a level setting slide about COVID. And the reason I put this slide is not to educate this audience. I know this audience is well educated and well versed into the basics of COVID. But certainly it is important that as we lead on this issue, and we have all been doing this, I will say the physician community has been doing this, researchers, the public health community, we have been telling the truth, right? We have been telling people what we know, but we have also been telling the public what we don't know, because we know that's how science works. Now, we can admit that that can be a little bit frustrating. You know, as physicians, we are used to that. We are used to keeping up with the literature. And when a new study comes out that requires us to change how we practice, we do that. And so we need to continue, I believe, to lead on telling the public what we don't know about this and be transparent. Because, you know, as a psychiatrist, I know that having the trust of the public is half the battle here. And we unfortunately know that because of a lot of misinformation and disinformation, we're having challenges regarding getting the science and the evidence and the facts out. But clearly, this is an all hands on deck moment as our cases continue to surge. And you all are seeing that in Oklahoma. We are seeing this here in Georgia. We have to be consistent in our public messaging. I think we all know that unfortunately science candidly has been under attack for several years. And even something that we know that we can do until we get further treatments or until we get a vaccine, even something as simple as wearing masks, unfortunately, has become mired in partisanship. But again, as physicians and as leaders in our communities, we need to, again, stick with the science and stick with the basic recommendations, no matter the headwinds against that. And we are sometimes battling headwinds. Again, a lot of misinformation out there on social media. Everyone is an expert. And so again, we need to continue to be consistent and clear in our messaging. You know, that is what the AMA has endeavored to do from the very beginning. You may recall that in April, we had some concerns that, again, science and the evidence and facts were under attack. And I gave a speech through the National Press Club about the importance of science and data and making sure that decisions regarding addressing this pandemic were based on that, were based on what the public health experts were saying and not what electeds are saying. And we encourage elected leaders to turn to physicians in their community, trusted physicians in their community, the public health experts. And so at AMA, we endeavored to be a credible source of information. Of course, you know, most our audience is mainly physicians, although we do have some information that's appropriate for the public. And of course, I had the wonderful opportunity to be in the media ecosystem and try again to demonstrate that AMA was a trusted source of evidence-based resources, and that we were also making sure that physicians and helping practices endure and recover from the disruption of this pandemic. And it was certainly during the midst of this pandemic where we were all appropriately cutting back on practice hours and doing whatever we could, we wanted to make sure that we still continue to work to reduce obstacles to care. We have a great website, and we kept really up-to-date information about our response and our recommendations on that website. But again, one of the many issues that COVID has brought to bear are health disparities and health inequities. Now, for most of us, of course, this was not new information. Health inequities and health disparities existed pre-COVID, but certainly COVID has exacerbated what we know. We know Black and Brown communities have been hit the hardest with COVID. And there are many reasons. I will tell you that the one reason, and you know, physicians have been on the lead on this, and we need to continue to be on the lead on this. It's not about blaming and shaming, and it's not inherently because Black people or who they are, Brown people who they are, and it's not about behaviors. It's really about long-standing systemic issues around bias, around discrimination, and yes, racism. You know, tough to talk about, no question, but we have to name and identify. That's what we do in medicine every day. We name the diagnoses, we identify the diagnoses, and then we develop a treatment plan. And so it's not easy. Even amongst ourselves, we need to review and have some difficult conversations. But certainly we must have these conversations. AMA was early on when we began to see the trends regarding the disproportionate impact, and knowing that some states had data, some cities had data. It was very disparate regarding the collection of data. And so one of our earliest calls was to make sure that HHS was collecting the data, but not only collecting the data, but also disseminating the data. And of course, as we began to learn, one of the many reasons, again, was about the disproportionate impact of the burden of chronic disease on communities of color. We saw that those who were older, those who had these chronic diseases, those who were immunocompromised had a higher risk of worse outcomes. And I think we all know that, everyone is at risk. And the science has evolved on this. Originally, I think there were some who thought that they could not even become infected. I said I spent the first 2 weeks of this pandemic talking with friends and family members because there was a myth in the rumor that African Americans could not become infected. And of course, as we have seen, there's a disproportionate impact. But everyone is being impacted, right? Every age, every race, every ethnicity. But clearly, chronic disease and the pre-existing conditions of brown and Black communities have caused worse outcomes. We also need to continue to weave in the importance of all of the determinants of health. We know healthcare is important. Whether or not you have access to health insurance is important. We know people who don't have access to health insurance live sicker and die younger. But there are other factors. Of course, genetics play a role. And now I'm not speaking about COVID. I'm speaking about our overall risk factors for health. We know individual behaviors do, but let me say something I always say when we talk about individual behaviors, because I think here's where those who are uninformed use this statistic, a data point, as a reason to blame. And I always say, absolutely, all of us make choices, but the choices you make are based on the choices you have. If you live in an area where it's a food desert and you don't have access to fruits and vegetables, you don't have the opportunity, you don't have equitable opportunity to make choices. If you live near an environmental hazard, and you have economic insecurity, it's not as if you can just go to the bank, get a mortgage, and move to an area with better schools, right? Or with less environmental toxins nearby. And so we need to make sure we appreciate all of these factors in context. In addition to talking about racism, talking about health inequities, certainly police brutality has come up in this particular time, not related to COVID, related to other incidents, not a new phenomenon, but an issue, again, that's interwoven into how we understand 401 years of racism and discrimination and injustice, which again is leading us to where we are today. And if we appreciate trauma, both chronic and acute trauma regarding racism, regarding episodes of police brutality, appreciate the vicariousness of witnessing some of these. And it's traumatic, absolutely traumatic, of course, to those who are experiencing and have individually experienced, but it's also traumatic for those witnessing. And we know that trauma certainly can relate to risk factors in health later on, not just depression and anxiety, but cardiovascular disease and diabetes. And that's why the AMA, in a statement that you see here on the slide, hopefully you saw this statement, the pleasure of co-authoring that statement with Jesse Ehrenfeld. He was chair at the time, I was president. We're now both immediates. But we felt that we need to raise this issue because it is a critical determinant of health. I spoke about trauma, and we know that trauma actually has impact no matter what age, but clearly we have the studies around adverse childhood experiences. When I was inaugurated last year, in June, I said, of course, in addition to the AMA's 3 strategic priorities, I wanted to raise the issue around issues around mental health and the importance of integrating mental health into overall health and our overall systems, the importance of diversity in the physician workforce, but not as an endpoint, as a point on our journey to health equity. We know and have some research that if you have a more diverse physician workforce, it can lead to improved patient health outcomes. And of course, trauma, and particularly childhood trauma. The data is clear. Early adversity has lasting impacts. And again, the question is, what are we going to do? What systems are we going to build? What resources are we going to invest? And again, let me just say this, because I know physicians in the audience, sometimes we feel like this is all our problem to solve. It is not. And we should not take every problem on. We do have a front row seat, though, to the health impacts of a lot of factors. And so we can lead in our communities by talking about what we see and holding our electeds to account, making sure the school system, making sure our, there's fair housing, and making sure that everyone has an equitable opportunity for a good education, safe neighborhoods, equitable access to physical activity. So again, not physicians' problem alone to solve, but certainly we can talk to those who are in power. We can speak truth to those in power and tell them what we are seeing in our practices. Specifically honing in on mental health, I am a child psychiatrist, and certainly we know that African American and Hispanic children have less access to mental health services and mental health professionals. Again, I have been seeing over the last decade increase in the number of suicides in Black and Brown youth. And so we have to make sure that we have the infrastructure necessary. Again, not physicians' problem alone to solve, but again, we see on the front lines the impact, and we can let others know about these issues. Now, we are certainly on our learning curve, right, aren't we, around children? And certainly we are having conversations, difficult conversations, complicated conversations about school. And the key is we as physicians have difficult, complicated conversations about health all of the time. And so hopefully we can lead and guide on having these conversations. What is the evidence? What do we know? We need flexibility. We might want to prioritize younger children. We certainly want to make sure teachers are safe. So again, I have to tell you, I'm a little bit frustrated by some of the arguments because I feel that if we use some of that energy on doing what we need to do to plan and prepare, it will be different for different localities. If there's a locale that has very low spread, they have robust testing and tracing capacity, they might be able to open school in person. Again, so rather than, have a debate, let's just focus on the science and let's make sure we have our children, our teachers in mind and work towards a solution. Because again, it's been tough on the kids. It's been tough on all of us. It's been tough on me. But children have had disruption in their lives. They are missing friends. And we've seen and do worry about, we've seen some increase in calls around intimate partner violence, and we want to make sure we have eyes on the children. Children are missing vaccines, and so we certainly don't need a measles outbreak on top of this. So we need to make sure we're having evidence-based debates about this. Again, advancing equity and a commitment to non-discrimination is built in our code of ethics. But of course, we need to move forward on this. In addition to our statement on police brutality, the AMA Board of Trustees made a pledge. And we recited that pledge at the beginning of our virtual meeting last month. that we do recognize that racism is an urgent threat to public health. We've talked about all the issues that we know lead to poor health outcomes. And so we wanted to make it clear that the AMA stood in opposition to all forms of racism, and that we are really working towards equity, doing what we can, both internally, again, and externally around racism and its impact on health. Of course, at the AMA, we do this through the many tools and levers that we have: policy, advocacy, toolkits. One of the things I'm proud of and that we're doing right now is we have a partnership with Essence and the NMA and other health organizations to really hone in on high blood pressure in Black women. And so for those of you who are watching, please go to this website, Release the Pressure, Essence//Release the Pressure, and take the pledge. We want Black women to know their blood pressure, monitor their blood pressure at home, in conjunction with their physician, develop a wellness plan, and make sure they check in with their squads all the time, not just about their blood pressure, but about their overall wellness. We have a long-term partnership with the American Heart Association on Target BP. So it's really a part of the AMA's work on chronic diseases. We have a partnership with the ADA around pre-diabetes. We want to move upstream. Again, a lot of policy around child development. AMA has a lot of policy around integrating mental health care. But again, we need to make sure we put this policy into action. We know that physicians from communities of color are underrepresented, and we really need to do all that we can to make sure that we begin early, pre-K, if you will, to establish pathways for underrepresented groups. Of course, to go into any field of medicine, of course, we all hope they become physicians, but we certainly want to draw more physicians, more diverse physicians into our profession. We've had a lot of initiatives over the years. You see Dr. Jerome Adams here, or you might see me, I'm not sure. But if you see me, you're not seeing a great photo we have of Dr. Jerome Adams. We typically had a doctor's back to school program, and that was sort of a one-day affair. You know, sometimes people can't believe something until they see it. And so that was just one way to see physicians from underrepresented groups in person. They were able to ask questions. We know that student debt is an issue and affordability of medical school. And we had a longstanding, have a longstanding partnership with the AMA Foundation. Of course, we've had to fight in the courts and through our advocacy work regarding our international medical graduates who are so important to our profession. And we've been, again, fighting in the legislative branch as well as the courts to support those colleagues. Again, we're very excited about our work that we're doing regarding the physician pipeline through our Accelerating Change in Medical Education initiative. We have to look at our medical school curriculum. Dr. Pasha might say something about that. And I wanted to say something about our AMA Center for Health Equity. We just established that thanks to the wonderful policy of the House of Delegates. And, you know, Dr. Aletha Maybank, who is our first Chief Health Equity Officer, has hit the ground running. And we're so looking forward to the work, looking inwardly as to what we do at the AMA and continuing our partnerships throughout the country, really, as we advance and center health equity. We have said we want health equity to be embedded into the DNA of our organization and throughout our profession. And I look forward to working with OSMA on these issues. I will be off the board at the end of June. I still have another year, but I will continue this work, and I continue to look forward to further opportunities. So thank you very much.
Dr. Harris, thank you. Great job. We're so lucky to have you here with us today, and we appreciate you and all that you've done. And you've really been a trailblazer. We appreciate you. So with that, we will go to our next speaker, Dr. Pasha.
And I apologize. I mispronounced Dr. Pasha's name, so apologies for that.
No problem, Dr. Harris. Dr. Monks, thank you. It's quite a privilege to be invited to speak on behalf of the OSMA and alongside Dr. Harris. And so I'm really excited to do that. I'm gonna share my screen here. I've got a few slides as well. And so, the title of my portion is what determines the health of our community. And we're gonna spend some time talking about the health of our community, but I think a more important question to ask is what determines the health of our community. As Dr. Monks previously mentioned, I'm Assistant Dean of Student Affairs and an Associate Professor of Medicine here at the School of Community Medicine. I also serve as the President of the Board of the Tulsa chapter of the American Heart Association. So some of the data that I think is important to discuss in regards to some of the racial disparities that exist in Oklahoma. We're gonna kind of take what Dr. Harris spoke about and zoom in and look at it from the perspective of our state and some of the communities within our state. And what I want you all to pay attention to is not only the absolute percentages, but also the trends. And in terms of individuals suffering from obesity, you can see a pretty sizable disparity in the Black community here in Oklahoma. And maybe most notable is that of all of the races and ethnicities listed here, essentially the only one that has had an increase over the past several years. Also, we see similar numbers here with our American Indian population, multiracial individuals and African Americans suffering from strokes at higher rates than some of the other populations. And again, if you check the trend that our African American community is seeing, you can see that this is trending in the wrong direction. Rates of diabetes also reveal some pretty significant disparities in our communities here in Oklahoma, specifically with our Native populations. And you can see the incidence of diabetes is about 17% in our American Indian population. And oftentimes we attempt to explain these away by saying, oh, it's genetic. We actually know this not to be the case. If you take a look at the Pima Indians, which is a tribe that is out of Mexico. And if you look at the rate of diabetes in Mexican Pima Indians, the rate of diabetes is about 8%, well below what we see here in Oklahoma. If you look at that same tribe that live in America, the rate of diabetes is as high as 40%. And so there's something to do with the Western way of life that disproportionately affects some of our cultures here. Taking a look at the death rates from cancer in Oklahoma, and you can see a similar picture as to what we've seen with some of the other disparities with our American Indian population and our Black population suffering higher rates of death from cancer. And a topic that's often overlooked in the Black community is the issue of mental health. I know this is particularly important for Dr. Harris as a psychiatrist. And you can see that African Americans and multiracial individuals suffer from much more in the way of poor mental health than other communities. These disparities are not only seen in the adult population. In Oklahoma, we see a staggering disparity in infant mortality with Black and non-Hispanics leading the way when compared to the other group. Again, highlighting continued issues with equitable health in our community. And these disparities ultimately become the product of what's summed up here. And this is a map of the city that I live in, Tulsa County, and we can see some life expectancies listed here. And if we take a deeper look, this line essentially demarcates North Tulsa from South Tulsa. And you can see the life expectancy in North Tulsa zip codes is significantly lower than those who live in South Tulsa zip codes. And this has gotten a lot of attention and has really led to us asking the question, why? And typically when that question comes up, the attention generally turns to access, with the hope that if we can grant better access to some of our underrepresented populations, we might expect to see some of these disparities, these gaps begin to close. And you can see our Hispanic population here in Oklahoma, our Black population have lower rates of insurance. And this has been a big deal over the last several months here in Oklahoma. And this is a picture of Ashton Gore, who is one of our medical students. We also have Niall McCullough in the back right corner, who have been advocating for Medicaid expansion for months. And as you all know, on June 30th, Medicaid expansion passed by a whopping 1%, but it passed nonetheless. And so the hope is that with better access, increased insurance coverage for our communities, we may hope to see some of these gaps close. But I don't know that we can be so sure that that's going to be what is really going to put us moving in the right direction. And so this picture here, I think, sums up the US healthcare system. And I'd love to claim credit for this analogy, but it goes to a colleague of mine, Dr. Pete Aaron. And essentially what this analogy is representing is our healthcare workers, our frontline workers are standing on the banks, and we are armed with determination and nets. And we are catching these patients who are stuck in these rapid waters, and we're pulling them to safety, right? That's how our healthcare system is set up. But the water's moving too fast, and there's way too many patients, right? And so many patients slip by. What we really should start to do is get our resources from the banks and walk upstream and prevent these patients from falling in the water in the first place. Our resource-rich country pours money into the healthcare system. We spend $3.5 trillion per year on healthcare in our country. And although we spend the most of any country, when we look at our peers, our outcomes are 11th in the world. And so we aren't getting the bang for our buck, if you will. And a lot of that is because we have tended to overestimate the impact of healthcare on health. And that may sound startling coming from a fellow physician, but the healthcare that we provide probably only accounts for 10% of an individual's wealth. And so we really have to start looking at other factors that actually contribute much more significantly to the health of an individual, and maybe more importantly, the health of a population. And you really can't look at that without recognizing this here, is that race and education and social status are so well married to each other. It's almost impossible to divorce these three things because they are correlated so tightly. And that'll make a little bit more sense as we kind of move through the rest of this presentation. And as Dr. Harris mentioned, we really have to begin training on the next generation of physicians to practice medicine from a different perspective. We know that socioeconomics, education attainment, childhood development, environment, and racism and discrimination contribute significantly to health. And one thing that I think is really important to mention is that it can be counterproductive to mention these disparities without giving the why, because that opens up the floor to false narratives as to why some patients some populations have poorer health than others. The narrative that it's genetic, it's not. The narrative that it's the fault of these communities, it's not. And we'll talk about why, as we kind of get through these 5 topics here. In the area of social economics, we always hear that money can't buy happiness, but it surely appears that money can buy health and wellness. There is a very linear correlation between income and health across all incomes. Those who are living in poverty as a whole have poorer health than those who are the lower middle class. Those who are middle class or upper middle class have better health than those who are lower middle class. And those who are upper class have better health than everyone else. There's a very strong and linear correlation between income and health. We know that educational attainment is another important factor that contributes significantly to the health of a population and the health of an individual. And don't confuse this with health literacy or health education. More important than health literacy and health education is actually general education. And unlike income, where there appears to be a very linear correlation, in terms of educational attainment, there is a level that once you reach that level, any more education above that doesn't lead to a person or a community being any more healthy. But the education that happens in early childhood and achieving a college education can work wonders for an individual's health. The problem is that the quality of education is not equal across our communities. And poor communities are at a disadvantage from the get-go. And it's because the local tax structures lead to underfunded schools in low-income neighborhoods. And because the schools are funded by income tax and property tax, when you have communities who have no businesses to generate income tax, when you don't have living situations that generate high property taxes, these schools remain underfunded, and the quality of education that the children receive limits them and ultimately affects their health. Childhood development is really important, and Dr. Harris touched on this. The research around adverse childhood experiences is extremely eye-opening. And we know that what happens during a child's upbringing significantly impacts their health as an adult. And so for children who are living in homes where they may be abused, whether it's physical, emotional, or sexually, if there is any neglect, if they're in a household with household dysfunction, an incarcerated relative, family member living with mental illness, substance abuse, divorce even, these add up and impact their chances for having a healthy life as they grow up. And this is a linear correlation as well. So as the number of ACEs increases, there is an increased risk of negative health outcomes, which includes behavioral health, increased risk for alcoholism, drug abuse, smoking, increased risk for poor mental health, and of course, physical health as well. And we don't have to go outside of our state to find communities that are living in poverty. This is a picture from right here in Tulsa, and highlighting how housing and environment can contribute to health as well. So in Oklahoma, we have significant issues with food access and food insecurity. And this is essentially defined as issues obtaining adequate and healthy foods. And Oklahoma has some of the worst food insecurity in the country. 15%, almost 16% of our households are food insecure. 80% of Tulsa Public Schools students are qualified for free or reduced lunch. And we have 218,000+ children who have issues accessing healthy food. Adding to that is the fact that Oklahoma is fourth in the country in fast food restaurants per capita. And a few years ago, this was highlighted here in Tulsa, where there was no grocery store, but there were fast food and Dollar Generals on seemingly every block. And with the community unable to access healthy foods, they turn to what's available. And that continues to kind of perpetuate the disparities in health that exist in our communities. Zooming in on Tulsa a little further, 38% of the residents who live in North Tulsa, predominantly Black part of town, are food insecure. And this is compared to only 10% in South Tulsa. 54% of residents in North Tulsa have access to fresh fruits and vegetables compared to 92% in South Tulsa. And I think this is maybe as striking of a statistic as there is. For those who live in North Tulsa and rely on public transportation, a round trip to go to the grocery store can take as long as 4 hours. And so you can understand why it would be much more reasonable to go to what you have in your community. And although it's not the safest or healthiest option, it's the most realistic. Environment, again, we know that unaffordable housing forces community members to live in standards of living that impact their health significantly. These poor living situations are a significant part of these disparities. And minorities aren't concentrated into certain communities by accident. Policies through the civil rights period called redlining put minority communities together. They prevented them from getting out of these communities by preventing them from getting mortgage loans. And so this isn't by accident, and it's not their fault that they're forced to live under certain situations. We talk about generational wealth often. This is what generational poverty looks like. Additionally, in these environmental issues, we have communities that lack green spaces for outdoor activities. There's no sidewalks. There's poor lighting, and the absence of lighting actually is correlated to safety of neighborhoods. And so when you have a situation like this, it's not surprising that individuals are not getting outside to exercise and be outdoors, further contributing to poor health of these communities. And then finally, the impact of racism and discrimination. And we talked about some of the policies, structural racism like redlining that have concentrated Black and brown people in certain communities. But racism in itself, the perception of racism itself is an independent risk factor for poor health. And this is when you control for access to healthcare and insurance payer status. Living with the stress of racism, the hypervigilance of being a Black or brown member of a community leads to increased cortisol. It leads to increased catecholamines and impacts health. And I kind of think of it as akin to a basketball team that always has to play on the road, right? The stress takes a toll and it impacts our health. Additionally, the impact of implicit bias is worth noting. This is a particular area of interest for me. And we know that implicit bias itself, when you control for other factors, contributes to these disparities. The Institute of Medicine did a sweeping review of healthcare in the United States in regards to implicit bias several years back, and they found that across the board, minorities receive poorer care. They found disparities in heart disease treatment, stroke treatment, diabetes treatment. They found that minorities were less likely to be referred for surgeries. They were less likely to be referred for dialysis. they were less likely to be referred for organ transplants, yet more likely to be referred to have limbs amputated. And so we have quite an uphill battle. And I do think it stems from the way that our society has been built, and really to enact change and improve the health of our communities and have an equitable healthcare system. We really have to start diverting these resources to policy changes and really fighting health from the inside out. We tend to think of health as an absence of disease, but health happens well before an individual's risk of disease happens. And so with that, I think one amazing reference that I think all physicians, or those interested in healthcare, should look into is this text here. With that, I'll turn it back over to Dr. Monks.
Excellent job. Those things you showed us were really eye-opening for me. And anyway, I really appreciate you presenting those. Very good points. We have a couple of questions.
Thank you.
The first question is for Dr. Harris. Dr. Harris, considering the disparities within the oncology space for a person of color, does the AMA partner with any specific organizations to address this with either screening, diagnostics, et cetera?
So hopefully you know that at the AMA, particularly around our House of Delegates issues, of course, and of course, we just had our president, Barbara McEnany, who is an oncologist, who has done some great work, actually, just separate and apart from the AMA, about oncology models and that. We don't, at the AMA, have any specific clinical partnerships because, of course, we leave the clinical work mainly up to the specialty societies. At the AMA, we are mainly where all of the states and all of the specialties come to develop priorities and policy. And so that is mainly where we have our impact. And of course, I can tell you that the oncologists are critical partners in developing policy pertinent to, again, looking at disparities, because that's critical. Because we know that for certain cancers, again, African Americans are disproportionately impacted for several reasons. So no specific partnership, but definitely our oncology partners are critical voice in the overall House of Medicine.
Great. Here's another question, and this is really for both of you. Talking about racial disparities, do you think having more Native American or ethnic doctors will improve more access to healthcare?
Yeah, I'll take that. We know from research that a more diverse healthcare field actually takes better care of patients. Outcomes go up when there is a diverse healthcare field taking care of patients. And so at least in Oklahoma, access really isn't an issue for our Native population because they have access to healthcare through their tribal affiliations. And so that actually is an important point to highlight, is that it's generally not access that has led to these disparities. We have tended to think over the years that access is the biggest factor as to why some communities have worse health. There's a really big study that was done in the UK where they looked at this, and it's still ongoing. It's been going on since the 1950s. And in the UK, they have universal health care, right? So our access is pretty much a wash. Everybody has the same access. But these racial disparities persist despite access not being an issue.
If I could, and this will probably be my last statement because I have another meeting about racism and public health, and I am going to steal, may I steal the issue around, because I think it's those narratives, the round trip to the groceries, 4 hours. May I steal that specific example? Because I really appreciate that, because sometimes we talk in these huge terms and we need those very focused examples. And I'm a sports fan, so I liked always, being on the road in hostile environments. I will say something clearly, diversity of a corporate board, an organization, leadership, the data is clear. You can go to the Harvard Business Review that organizations perform better when there's diversity of thought, opinion, and people. But of course, that is just a part of the puzzle. And I know no one thinks this, but I think we should be explicit about the fact that we all own the responsibility of providing the care. I think there was one study that showed that Black men followed the advice of Black physicians more, Black male physicians, actually, I think more. But of course, we don't want a society where only Black people treat Black people, only Native American physicians treat. And so really all of us have to own the responsibility of the capacity building and understanding and that culture of humility of treating everyone and being informed by colleagues who don't look like us. And with that, so I can get on my other Zoom, let me just say thank you so much for the invitation. I think I am an honorary Oklahoman. I think I was there 2 years in a row and couldn't make it last year because of a commitment. But I hope that someday to get back. And again, thank you. What an honor to be able to present before you today on this important topic.
Okay, well, thank you so much. And I know you've got to go. We might do one more question with
Yes.
Dr. Pasha, but Dr.
All right.
Harris, we look forward to seeing you in the future at our meetings.
Absolutely. Take care.
Thank you. So we've got one more question and we'll wrap up, Dr. Pasha. Healthcare is tied to lots of other social issues. In the UK and Europe, they have broken the social issues by requiring all new construction of a community or apartments they call flats, that 10% of the property must be assigned to the public housing. That means all kids go to the same school. Would you have any comments on that?
Yeah. You know, because where you live is in our country, where you live is tied very tightly to what your race is, which is tied very tightly to your income and your level of education. Finding policies that allow mixed incomes to live amongst each other are policies that I agree the data supports that that helps communities pull out of some of the social holes that they are in. It helps them access better quality schools. It allows them to access healthier foods. And so absolutely. And that argues the point, again, that we really should be attacking this problem from the perspective of the policies and really look to invoke policy changes to improve our health. And when you improve the health of a community, you improve many of the other social factors and vice versa.
Well, I think that was great. And with that, we're going to wrap up. And I appreciate everyone's time today and all that you do. I appreciate you. Thank you.
Thanks for having me, Dr. Monks. It was a pleasure.
Thank you, Dr. Pasha.